First of all, good morning, everybody. You're very, very welcome to today's session, which is part of the HCI webinar series. This is our first webinar of 2026, hopefully not our last. My name is Oonagh Gilvarry, and I'm the Chief Research Officer in HCI. And today, what I'm going to be doing is presenting some of the key non-conformance findings from a selection of the recently released HIQA inspection reports from the designated centres specifically for older people. Also, what we're going to do is spend a little bit of time looking at some of the basis for these non-conformances when we look at regulatory compliance. So I'm going to be discussing some of the key documents that were released in 2025 and looking at how they should currently be incorporated into your processes, into your policies and procedures to ensure regulatory compliance, and obviously from that ensuring the quality and safety of care. I'm also going to be joined by my colleague Louis Coyne, and he's going to be presenting us with one of our digital solutions, Cloda, which can help to address some of those regulatory challenges that you might be facing at this stage. Okay, we will kick on. We have a lot to cover, so it's best to get moving on it. Just very briefly, for those of you who may not be aware of who HCI are, hopefully you do, but as a refresher, we help providers of health and social care make intelligence-driven decisions to attain, manage and improve quality, safety and regulatory compliance. And we do this through streamlining, improving and transforming your internal processes with a specific focus on safe, quality services for your residents. At this stage, we're well over 20 years in business, and we have in excess of 40 individuals on staff now with a range of health and social care discipline experience in that regard. So as I said, first of all, we're just going to look at some inspection reports. We took a sample across the board. These inspection reports came from the last two batches that were released from HIQA. The last one, on the 9th of December, there was a significant batch released, and then another on the 13th of January. Now, a lot of these inspections happened over the tail end of the summer into the autumn, but it's the most up-to-date information that we have available to us. And we're going to be looking at some of the key areas of interest and types of findings that are coming through under each of the regulations. And as I said, after that, then we're going to look at some of the driver documents that we believe are fundamental to the issues that have come through. So under the first dimension, you'll forgive us, we won't start in chronological order. We're going to look at governance and management. We always start there, as do HIQA indeed, and look at some of the findings in that regard. One of the significant findings when we looked at across the swathe of the inspection reports, governance management is still carrying far and away the most significant number of services carrying non-conformances and red risk non-conformances in that regard. So, you know, processes are a long time embedded now within our sector, but because of some of those fundamental changes, and we'll talk about SI1 and SI98, the big legislation changes that came through for older people's services at the beginning of last year, there's a significant push in relation to governance and management and the regulation focus in that regard. Oversight and staffing being, from my perspective, when we looked at the trends that are there, being the significant elements that there's focus on. Audit systems particularly had a significant amount of focus, and they felt that the models that were being implemented in many of organizations simply were not identifying major risks. And we often say, you know, it's an inspection, a HIQA inspection, it's not like the NCT. We don't want to run it through and see what our problems are at the far end. They want to see that our services are implementing effective audit systems that are proactively identifying risks and getting out ahead of the problem. We don't, you know, in many organizations, there's a reluctance to really have a lot of detail in their audit reports and audit findings, that we don't want to really put them down on paper. That's not the approach we need to have. We need to have that open-handed approach where we're significantly investing time, energy, and resources into our audit practice that's effective and comprehensive in identifying risk. And that gives a confidence to our regulatory, to the regulatory body that we're ahead of the game, and we're on top of it in that regard. So some of the problems they identified in relation to audit systems, we had significant misalignment between audit results and audit practice. So everything looked tickety-boo in the audit reports. Was this because it was a box ticking exercise? Was it because the auditor themselves wasn't sufficiently tenacious or hadn't sufficient training to complete an effective audit? We don't know, but there definitely was a misalignment in that regard. So we need to ensure that our audit process is really comprehensive, effective, and is identifying real risks that are very evident, obviously, in actual practice. In another case, we had audit effectiveness and impact they felt were very limited, as it wasn't auditing key areas of risk which were clearly found on the inspection day. So in this element, the audit schedule wasn't comprehensive. We were just auditing little bits and pieces that maybe they felt was appropriate, but it didn't have that comprehensive approach and auditing key areas of risk. And it's important to know that if we do have an area of risk, that it's not just, a once in a year visit that we'll pay to it, that if there is an area of risk, that we're giving it more time and focus in the audit practice. Fire can come in under any of the regulations. It pops up everywhere. In this case, they felt the fire risks were missed, again, by internal audits. And again, maybe this is a case where we don't have the expertise on site to be able to, we can't be experts in everything, but it's really important that we identify if we don't have the expertise to complete the audits, that we bring people in with the expertise and the knowledge to be able to identify the risks at a systematic level. IPC audits, again, failed to flag unsafe practices. We had issues with sluice room chemical preparation and storage trolleys in contaminated areas. Again, why was this the case? Is it, again, lack of experience or expertise being applied, or is it really just that people are likely skimming over daily checks and not really completing detailed IPC reviews? In this case, we had a wound audit that actually detailed inconsistencies. So it had identified that there were problems in the care practices, but there was no follow-up for over 2 months. So we had a good audit practice with good auditors. We had detailed it in the report, we identified a problem, and then it just sat there. So this is really important, that where we have teams and our teams and committees, that there's a clear terms of reference, and we incorporate the review of audit actions, that monitoring and ongoing review and closeout, that is clearly detailed in our terms of reference, that there's responsibilities allocated to teams or individuals to ensure that closeout happens. No point doing all the good work up front and then it falling at the final hurdle. In another case, there were improvements required in relation to accessing audit data and quality improvement plans. The provider had an electronic audit system, had a lot of good work done, but on the day could simply not pull the data out, which is certainly not where we want to be. We want to be able to illustrate all the good work that's being done when the inspectors come on site. In other cases, issues with weak or dysfunctional organizational structures, and again, roles not clearly defined, especially between CNMs, ADONs, PICs, and managers. Job descriptions really of a significant focus here. We need to make sure that we have a lot of detail in our job descriptions, that there's real clarity on the roles and responsibilities. And with all of that new regulation and best practice and national policy that came out in 2025, we need to be going back and reviewing those job descriptions and making sure that the roles and responsibilities are really clear and that there's individual accountability that is specified within that regulation and it's clearly detailed in our job descriptions. Also, really important that we have delegates in place for all of those roles. If somebody is unable to come to work, who's going to step into their shoes and fulfill those roles and responsibilities that are critical to the quality and safety of care? In another case, change management, they felt created instability. So there was a high turnover of PICs and CNMs. Certainly, turnover of staff and management staff particularly is one of the key KPIs we would recommend that is reviewed and monitored on an ongoing basis. And certainly, I think HIQA would be expecting to see that if there is a high turnover creeping in, that there is some form of analysis completed to try and identify what was the core issues that was causing this level of turnover. Because there is no doubt about it, in relation to if you have high turnover, that instability certainly impacts on the quality and safety of care that's being delivered. In other cases, there was issues with escalation process. And we often talk about that in your policies and procedures, in your process you're implementing. We obviously, in our process, we know what we do. It's a step-by-step process. But what happens if something goes wrong? Who do we escalate it to? What is the go-to process when an issue may arise? In this case, staff didn't seem to know who was on charge on night duty, and they didn't know what to do if any particular issue arose. So that's really important that we're considerate of that when we're reviewing our processes and our policies and procedures and rolling that out to our staff. A couple of the reports identified, surprising, there was failure to meet restrictive regulatory conditions. So coming from a previous inspection, there was failure to ensure deficiencies identified or previously addressed and promised works were not completed on time. So again, linking back to those responsibilities for audit findings, even more so, really important that there's that we whatever commitments are made in relation to actions to HIQA, that we follow those through and ensure that they're implemented accordingly. Incident management always gets a good bit of focus. In this case, again, something like the auditing and I suppose being a little bit just skimming along the top. In many cases with incident management, the issues were about not doing root cause analysis. I mean, what we see all the time in relation to incident management, retraining is one of the most popular corrective actions. Retraining is rolled out. How effective that is depends on the repetition of the incidents that are coming through time and time again. And if the same issues are coming through, it's pretty clear that the root cause analysis isn't being effective in addressing the systematic problems that are there. In this case, we had records of unexplained injuries, which lacked sufficient investigation to rule out safeguarding concerns. And I'm going to talk a little bit about safeguarding and particularly in relation to the national policy framework for safeguarding that came out in December in a little while. But certainly safeguarding is going to come under a significant amount of focus as we move into 2026 and beyond. We'll talk about that in a little while, but certainly if there's anything coming up in instance in relation to that regard, we need to be very, very thorough in our approach. The HSE sexual safety framework that also came out this year, we'll have a look at. And that again has very clear requirements in relation to our response to any allegations of abuse in that regard. Trends and falls in incidents not being properly investigated, being, I suppose, treated as singular events rather than potential trends across the organisation. They'll be looking for us to be able to identify those. And general analysis of information through incidents didn't always seem to lead to quality improvements and outcomes for residents. So again, at that kind of piecemeal effort, but not really impacting on the quality and safety of care based on the actions that were coming out. Risk management, certainly it's a significant element of the governance requirements. In this case, again, good work done up front, risks documented, but again, those control measures falling down, not being implemented. So that close out of the loop certainly repetitively coming through in Regulation 23 in that regard. Now, I've spent a good bit of time in governance. I'll have to speed things up as we move through the regulations. Staffing, as I said, under SI 98 got a little bit of attention too. So what was the key elements of findings there? Generally throughout, the biggest element was insufficient staffing to meet residents' needs. There was a lot of focus time on that, on rotas, seeing the applications, measuring it against the dependency levels of residents. So in this case, the provider had not ensured that there was sufficient number and skill mix of staff available in the centre to meet the assessed needs of the residents. So from an overall perspective, based on dependency levels, they felt that that number was insufficient based on the outcomes of that were there for residents. They felt inadequate numbers of HCAs and nurses, resulting in long delays of care. And there are very clear indicators. If there are insufficient staffing, there are clear indicators, and they feel that those delays for care are certainly one of them in that regard. Another one will be where we maybe start to shuffle staff from perhaps activities and try to move them into other services. We'll look at that in a little while also. Staffing levels for high dependency units were not adhered to. We had short-term absences that were not replaced. We'll just try to manage, we'll patch it up. And you know, I understand these are not easy questions to have answers to in relation to staffing, but these are the types of issues that were pulled up. Residents told inspectors that the centre was often short-staffed, particularly during weekend day shifts. So the residents themselves had identified that there was trends in relation to issues for staffing. So they knew coming into the weekend, it's going to take longer for me to get responses. I might be later getting out of bed. I mightn't get the activities that are promised, and that there was clear indicators that there was issues in relation to staffing. Just wanted to put that note. This again is one of those requirements from SI 98 of 2025. Registered providers should ensure that the designated centre has sufficient resources to ensure the effective delivery of care in accordance to the statement of purpose. So that was one of the new requirements that was incorporated in there, and certainly it's one of those that they are spending a lot of time and focus on within the service inspections. Other staff management failings: no risk assessment before reducing rostered staff, staffing resources not being organised to support daily activities, and we'll look a little bit closer at that one in a minute. And then gaps in shifts not being escalated or filled. Training and development then linked to that. Again, they link this to inadequate staff supervision, seemed to be the biggest element that was coming through under this regulation, where staff were observed breaching IPC standards. They were not sanitizing their hands or wearing gloves, and disposing of incontinence wear in bathroom bins. And either that it relates to supervision or training, whatever the case may be, but they felt that it was primarily driven through issues with supervision. In general, they felt supervision of care was not robust in another service where you had pressure injury prevention and care being poorly monitored. Staff observed using hoists and slings and mattresses inappropriately. And in other cases, staff were observed using personal mobile phones when supporting residents, which is obviously not where we want to be. Other issues, both flagged red and orange. Staff were not knowledgeable or did not have access to the regulations or standards. It's very, very clear they expect staff to have a clear understanding of their roles and responsibilities within the regulations, and that they have easy access to that information, and that is kept refreshed and up to date. There's always a number of issues in relation to mandatory training, CPR certification missing for registered nurses. We had out-of-date safeguarding training in a number of cases, and then the documentation to support the training that was done also had a number of issues where we had records didn't have evidence that all of the staff on the rosters had completed the mandatory training, and in other cases retrospective recording was observed, and we certainly don't want to have anything to do with retrospective recording. Just briefly in relation to records, and I specifically just wanted to pull it up under the rosters, a lot of focus there. Rosters, the issues being that they're unreliable or unavailable. In one case, we had 4 different roster systems in use. Nobody seemed to know exactly what roster was being applied. Night staff were unable to access a roster. We had planned rosters that clearly didn't match on worked rosters. And then we had staff on leave that were clearly detailed as working, so that there was a clear mismatch in that regard. Also, just under records, care records not being complete. We need to make sure that, we're doing that monitoring of the care records and keeping them where they want to be, that we have good GDPR in that relation, that good documentation practice. In some of the issues, diagnostic test results not stored or available to staff when they needed them. Observations, neurological observations missing post-fall, repositioning charts showing 3-week gaps in some regards, and 15-minute location checks missing also. So certainly a monitoring process required in relation to our care records and making sure that they're where they need to be. Complaints procedure. Complaints went through an upgrade, I suppose, the SI 628 that came out, but that should be well embedded now in relation to complaints. But they found that in many cases, the complaints process was not reflective of the complaints procedure. So we had a reasonable procedure, but it wasn't getting implemented when complaints came through. In some cases, we had inconsistent evidence, not consistent evidence of complaints being acknowledged within the required time frame. And there's very clear time frame requirements. Your service, detailed that you must acknowledge the receipt of your complaints within 5 working days. it's very clear we need to make sure that that's it, that the timeframes are implemented. In another case where a resident wasn't satisfied with the outcome, this wasn't escalated to senior management. So again, we bring it so far, but when the resident wasn't satisfied, it wasn't escalated to senior management, and it also wasn't communicated of the additional reviews, internal reviews and external supports that were available in that regard. Residents and families spoke of their apprehension in submitting complaints due to potential repercussions. So that's a really significant one. I mean, that really points to issues with the overall culture of an organisation and would be a key indicator to take in that regard. We really need to ensure that our complaints process and the way that we approach it with our staff and with our residents and their families, that we see it as a gift. You know, we have to take those complaints on board and address them appropriately, ensure that the supports are there for for those who make the complaints, be it through advocacy services or additional supports that are required, and that we're very clear in our responses. Now, we had the HSE open disclosure policy also reviewed in 2025, and that also links to, in some regard, in relation to complaints and the way that we manage them and our openness to feedback and our receipt. So that's really important to consider. A resident spoken with was not aware of the complaints process, and despite discussing their concerns with staff, no complaint had been logged. So again, ensuring that the process itself is made openly available to the residents and their family. And obviously, if a complaint is verbally made, it's just as important as if it came in writing, that it is sufficiently logged and managed accordingly. Under the quality and safety dimension, Regulation 5 then, individual assessment and care planning. Primarily here, the issues were about not updating care plans in line with resident conditions and then inconsistent with the actual care plan being provided. So residents who experienced weight loss did not have updated assessments. In many cases, care plans were not linked to assessments. So assessments were being redone, but that wasn't filtering into the care plan interventions that were implemented. Most scores were missing or inaccurate. In some cases, care plans were found to be very generic. They weren't reflective of the individual needs of residents. And in another case, a resident who was on a high-risk malnutrition pathway, yet staff did not know or were not aware of the resident's dietary needs. Managing behaviour that was challenging. And again, as I said, we have a lot of movement now in relation to safeguarding that's coming down the line. So we need to really be on top of our game in relation to this. Some issues that came through here were specific in relation to restraint. Inspectors found that there were therapeutic holds, which are detailed as a form of physical restraint, were being used to support a resident during personal care. However, this had not been risk assessed in accordance to national policy. In another, residents' care plans did not detail a stepped approach to restrictive practice, ensuring that we start with the least restrictive and consider that implementation and how responsive it is before we move in to more restrictive responses. And then they felt that staff had not received sufficient training for the implementation of these types of therapeutic holds as restrictive practices. So protection, as I said, with safeguarding and that national policy framework, we're going to be looking at some additional requirements in this regard. But from the perspective of the inspection reports that we reviewed, what did we see? Well, some residents with a history of responsive behaviours, which were known as safeguarding risks to other residents, the measures documented to mitigate these risks were not always effective and had failed to protect the residents from abuse. So although actions were taken, it was clear that the effectiveness of those actions were not monitored and there was repetitive issues. And again, that links into our incident management, where we had significant issues occurring again and again, repetitive issues, so they obviously weren't being addressed at source. In another case, it was evident that not all staff had the required knowledge, experience, and skills to prevent incidences of abuse and protecting residents from harm. This was evidenced again by the number of responsive behaviour incidents, which had resulted in staff and visitors being assaulted and residents being upset and frightened. So again, the non-effective approach happening, which allowed this repetitive behaviour within the services, and it became normal behaviour, normalised within the environment, which is certainly not where we want to be. Incidents where residents were negatively impacted by responsive behaviours of another residence had not been recognised as safeguarding issues and therefore had not been investigated. So it's really important that it's not just the focus on the individual with the responsive behaviours, but those who are impacted are also part of that safeguarding framework, and that is addressed accordingly. One that I thought was important to flag up was in relation to serious incidents. Following a serious incident which adversely impacted on residents' care, the PIC failed to carry out a comprehensive investigation to fully investigate the incident, including any potential misconduct of staff. The vast majority of organisations have a reasonably good incident management system, which can manage what we would categorise as, or was categorised through the HSE, the Incident Management Framework, as Category 2 or Category 3 incidents. They're pretty good at managing that. Problem arises where we have a Category 1 incident, okay, whereas it is deemed as a serious incident. The process that's required for that, which is in line with the HSE Incident Management Framework, is substantial. It's a significant piece of work where an SAO has to be appointed and your investigation teams and the terms of reference are developed. It's a very significant piece of work. And it's really important that our incident management model is considerate of how that's going to work. And in many cases, services pull in external support to be able to support those Category 1 type incident reviews. But it's really important that we are aware that there is a level up, shall we say, in relation to incident management where a serious incident arises. And certainly if you review the HSE Sexual Safety Framework, it's very clear in relation to what they expect to see depending on the incident that arises and how it should be managed as a Category 1 incident. Resident rights, and one of the big things came up in residents' rights is in relation to activities. And I suppose making that difference between a life and an existence, really focused on the quality of life services that are being provided on a day-to-day basis. And that we saw this across the range of inspection reports that were reviewed. In some cases, they felt that there was very limited programs and that there was minimal stimulation in that regard. The schedule itself was very limited. Many residents spending long periods of time with no stimulation, and some units received no activities at all. Activities were not provided when other departments were short-staffed, where the activity staff were then redeployed to cover kitchen shortages. So that links back again to our staffing and short-term absences not being covered. In some cases, it seems that activities staff are the poor relations, and in many cases where the pinch comes, they're moved out and to fill other gaps, which is understandable and it's real life. But when this becomes a repetitive process and they're almost seen as extra staff that we can pull where we need them to be, that's where the problems arise. And there really is a significant drive in relation to activities, the quality of life services that are there, and ensuring that it's reflective of the preferences of the residents, and it is and that they're involved and integrated in the development of that programme for their general well-being and their quality of life. They also found issues in relation to privacy, handovers being completed in communal space in front of other residents and external individuals, and then resident information openly displayed in bedrooms, where it is not ideal. Other ones, staff practice in the environment, not promoting residents' rights. Some of these quite surprising that came through. Some residents were sitting in armchairs in day rooms to have their lunch meal, meaning that the residents didn't have access to the same dining experience as other residents. And this came in under food and nutrition regulation as well. Again, linked to activities and quality of life. Is the dining experience supportive of that quality of life? In another case, we had a resident who was trying to get up from a chair, was told to sit back down with staff, and certainly not the type of language we would expect to see. A resident who was looking to find the day room wasn't supported to locate it by staff, and they felt that in another facility, residents were unsupervised for long periods, and as a result, residents who are at high risk of falls were observed mobilizing without supervision. Premises, I'm not going to get into it, but it just always carries red risks. Just one or two that I've pulled out here is in relation to heating and hot water failures. In one facility's bedrooms had no heating during mornings or part of the night. Staff couldn't control the heating themselves. Only the provider could do it. We had no hot water in some parts of a centre, and then residents were washing using basins filled from electric showers. So certainly not where we want to be there. Sluice room access failures. In one case, staff couldn't open a sluice room for 15 minutes, meaning cleaning equipment could not be safely accessed. Food and nutrition, this links back to our dining and meal quality and experience and choices. So a menu not matching due to a staff absence, but primarily a focus was on the meal quality and the general experience. And in this case, they found that that experience was quite chaotic. There was noise and discomfort reported, undignified serving practices, lack of tray tables, residents struggling to hold their mugs, menu formats being inaccessible for residents with dementia, an absence of modified diets, lack of evening snack variety, and then generally, and again, in many cases because of issues in relation to resources, but they found that staff were distracted, rushing, or engaged with conversations with each other rather than focusing on the needs of the residents at that time. Infection control, always our reds and orange flying up to here. Obviously, we're looking to have all of our requirements from the HIQA standards, the 2018 standards for IPC in community settings being implemented. Primarily, they found issues with the oversight process, systems for ensuring oversight of IPC required review. And in one of these cases, the inspectors were provided with inaccurate information in relation to the number of residents who were colonised with an MDRO. So they didn't have a general oversight practice in relation to the IPC and issues in that regard. MDRO monitoring did not incorporate a robust review of actions to address any areas of improvement. We had issues also in outbreak detection, where we have an ARI outbreak was not identified despite 20% of the residents being symptomatic. Public health weren't notified, and there was no PCR testing. So that's a sample of some of the issues in relation to IPC. Again, fire precautions, always red. Not going to do a huge amount on that, just picked a couple. Unsafe evacuation capability, and the evacuation drills always come under focus and always seem to fall down. Drills not simulating worst case scenarios, practice for only one or two residents, not covering all compartments for the last 2 years, performed with unrealistic staffing levels, and that's a repetitive one. And then HIQA identifying that evacuation times were detailed as being dangerously long. Inadequate fire escape arrangements, again, these are elements that should be picked up on walkarounds, incorrect or unclear escape routes, fire gates locked, and our peeps lacking essential detail in that regard. So in summary, key areas, governance, particularly in relation to our oversight and monitoring and audits, and generally in relation to closeout of actions, be that from our audits, from our incident management, from our risk, making sure that if we identify a job needs to be done, who's going to do it, and checking that it gets done. Staffing perspective, really important, focus on insufficient resources based on care needs and being able, linking it to rights, supporting those quality of life activities, both from a dining perspective and our activities schedule, and from protection. And we're going to talk about that in a couple of minutes about our safeguarding processes and how we need to get ready for change. So what's driving all of these non-conformances? Well, general practice and day-to-day activities. Regulation has been there for quite some time. But in 2025, there were a significant number of key documents that came through. And we can see these having an impact on the inspections that are happening currently. SI1 of 2025 was the first, that was the big document we were preparing in 2024. It came out in 2025. It was reissued then under the remit of SI 98 as there was some additional changes made in relation to deputizing regulation 33 and regulation 14, the qualifications of a PIC. So now it's under that bundle. There was a swath of changes in relation to it. And I'm sure you've all spent a significant amount of time looking at those changes and incorporating them into your policies and procedures. But we can see the impact of those new regulations as we look through those inspection reports. Linked to that, I'm just going to skip down to the fourth point, that HIQA guidance for the assessment of the designated centres, that came out in May. And that really, I suppose, carried the guidance of what they expect to see based on those new edits and regulations. If we go back to the second point, the fire safety handbook, always under review, always pulling up high risk, really need to be comfortable with the content that's there and have the external supports and expertise available to support us in application. I've mentioned the HSE Sexual Safety Framework. It's a really good document. It has a lot of clarifications, as I said, outside of just sexual safety, but generally in relation to safeguarding, and it looks at your service, your say, and incident management category ones also. So give a lot of support in that regard, but certainly that document should have had a big impact on your incident management system, your incident management, and also on your allegations of abuse, your safeguarding and allegations of abuse, because there are particular requirements there should an issue in relation to sexual safety arise. Open disclosure, that policy was released in June. It was a long time coming. Again, some significant changes in that regard. Again, should have impacted on your incident management policy. Changes in a lot of detail in relation to apologies and management and timelines. So a lot of work in that regard also. And the Health and Safety Authority, they updated their health and safety at work in residential care facilities, changes there in relation to falls and that type of approach. Really important that we incorporate those as applicable. A couple, and I know I'm running short on time, that I just want to give a little extra bit that were quite recently released. The HSE National Procedures for Handling of Protected Disclosures, that was released in October. There were some changes here, primarily in relation to terminology, changing from areas of concern to concerns of relevant wrongdoing. More guidance given in relation to what should there be a response taken against a staff member who may penalise a reporting person. Give a good bit of guidance in relation to contents of feedback for anybody who may have made a protected disclosure, and then clarifications in relation to relevant information and reasonable belief, and what is the difference and what they can be defined as. A good document that came through just in December of last year was the HIQA National Guidance on Good Communication and Health and Social Care using plain language. Now, there was a document previous to this that HIQA released with NALA, but this has some really nice communication techniques added there. Techniques for vision impairment, deaf-blind, hard of hearing, dementia, AAC devices, or where speech is unclear. Really nice document, gives a lot of supports in relation to staff to support their communication techniques, and certainly one I think that is worth reviewing. There's a good checklist there also, how to know if you're communicating effectively. Again, support your staff training in that regard. Now, I've mentioned it a couple of times, the National Policy Framework for the Adult Safeguarding and Health and Social Care Sector, and it was just released in December of last year. What is it about? What does it mean for us? So we spent a bit of time reviewing this. And generally what it does, it's setting out over the next 5 years how adult safeguarding is going to operate across the health and social care sector. Now, designated centres for older people and disability services already are a long way down the road in relation to safeguarding. And there are many other services that are nowhere close within health and social care. However, it will mean changes for us going down the line. And that's why I'm saying that we need to be really robust and be really confident in the safeguarding processes that we currently have, and that they're reflective of all current requirements, because it is only going to build on top of those. So it's really important that we're comfortable where we are. Generally, what it's going to do, it's going to have a blanket approach across public, voluntary, or private bodies, and it is going to have supporting legislation to implement the requirements. The big element for the legislation is to extend the powers for the HSE adult safeguarding personnel to enter premises based on a number of criteria. And on that, we also have a new role for HIQA, providing independent oversight of the HSE adult safeguarding services. So they're definitely going to need to be supported by legislation due to those changing roles. What's it going to mean for us? Mandatory reporting of concerns of allegation of abuse. I mean, we're already reporting. Whether changes will come down the road on that is yet to be seen. And there's also going to be mandatory adult safeguarding learning reviews where we have serious incidents. It's going to expect us to complete service safeguarding risk evaluations to identify potential for harm or abuse. So moving into a proactive response in that regard, and on that basis, develop an adult safeguarding statement. No doubt has to happen. The HSE National Adult Safeguarding Policy 2014 has to be revised. It's well overdue. So that will be happening. And then we'll have the implementation of the overall framework over a number of years, and it's going to be reviewed again. Independent evaluation will be undertaken within 5 years. What does it mean for you currently? Certainly for ourselves in relation to the work that we do, we're reviewing the terminology that's utilised within our safeguarding processes. There's a lot of excellent principles that are incorporated within this about what they expect all staff responsibilities to be. So I certainly think it's important that you review it and you incorporate it in your current safeguarding process, not in relation to changes in relation to reporting. None of that detail is there, but in relation to the terminology, the principles and approach, they are certainly relevant. So I think it's very important to have a look at that. Now, with all of that said, issues in relation to non-conformances that we've seen and the changing horizon of regulatory compliance, how can we assist you? Well, I'm going to hand you over to my colleague Louis Coyne, and he's going to bring it through one of our digital solutions, which is Cloda, and we certainly believe that it can assist you in overcoming all of those regulatory challenges. So Louis, are you there?
Much, I am. Appreciate all that information and the handover. So let me just share my screen. Can you see the screen?
Not. Oh, yep. We're good, Louis.
So as Oonagh mentioned, we have a digital management solution, which is a quality and safety solution called Cloda. We have a number of features in the system, which is our library, which is our documentation management, our training room, where you can ensure you've got your mandatory training completed against your staff. And then if you have the permissions, you have the analysis to do the audit, the admin and configuration. Another service we provide that you might have heard of before is that we provide best practice templates for residential services. These are our HIQA best practice templates. And if it was part of the agreement with you, we would provide access to certain individuals through here. So with Cloda, for your frontline staff, it's how do they access your information that you can stand over in your policies, your procedures, your SOPs. So with Cloda front and center, I can ask questions straight away of my documents. So what should I do in an infection outbreak, as this is one of those high-risk areas? So what Cloda does is she interprets and interrogates your policies and procedures and provides that information back to your staff with those questions in just a number of seconds. So here you can see from the documents in this environment, and she can only query the documents that are in the system for your specific business and only those most up-to-date ones. Yes, you'll have a repository of all the obsolete documents that I'll show you in a minute, but Cloda can only access your active documents. So here we can see in the event of an infectious outbreak, the following steps should be taken. Report the outbreak, and we always provide the link to documents at each of these, which I'll show you in a second. So as we go down, you can see it's pulling directly from these two policies, which is management of viral infections and my management of an infectious outbreak, depending on each of the different points that come through. So what we can then ask is further questions saying, what risk assessment should I do, which is point number 2 there. And as you can see, I had a slight spelling mistake, so Cloda can interrogate that further and ensure that she's pulling the right information for you. And here you can see in the context of managing an outbreak, the following risk assessments should be conducted: health and safety, outbreak risk assessment, and so on. And I always provide the link, as we said, to that document. So the management of the viral infections, we can have all of that information related to that info. This is one of our documents, as I said, that we manage. And if I look at my management of an infectious outbreak document, you can see all the information as I scroll down again of how you would manage an infectious outbreak. What you'll note at the top, this document for me is outstanding. It requires an acknowledgement. And if I click on the link, what we can see is we've instigated a quiz for this specific document. So in this demonstration environment, we have determined that the management of infectious outbreak is a critical policy to the safety and security of our business and our care. So I have told Cloda to create an MCQ on this document. And what she's done is she has created a set of 10 questions, and I selected 6 for this policy and procedure. So what's the role of the medical officer, which is a standard precaution when we're dealing with residents, it's hand hygiene. What should staff do if they notice signs of infection? What should be done immediately afterwards? And what should be done to ensure the safety of an outbreak? I'll just answer the last 2. So as you can see, I got 4 out of 6 correct here, but we're instigating that I have to get 100%. So I have to reread the document and retake the quiz before I can acknowledge that policy and procedure. Now, the quiz is not mandatory for every document. You determine which document requires it. And what we've been able to demonstrate already in the last 12 months is that without the quiz, critical care policies are being acknowledged in less than 3 seconds. With the quiz, that's up to 3 minutes. So you can demonstrate to HIQA and to your management team that documents are actually being read, they're being understood, and you've got that training element on top of them as well. So if I wanted to go to my library here, you can see this is all of our different tiles of how we've laid out these documents. And in here in my nursing home demo, we've got them under the different themes for the HIQA national standards. So in my infective services, we've got 17 documents in this demo environment. You can see these have already been acknowledged. And within my full list, we have 67 in here, and I've got some outstanding as I just demonstrated with you. Whereas if I scroll down, you can see these documents here that were acknowledged, they didn't have a quiz associated with it. So again, it's only determined on specific documents. As I have the permission set in here, I can update and revise and edit documents, and I can see all of my previous revisions. If I look here and look at the previous revisions, we've got those obsolete versions with the changes from the SI 98 as Oonagh outlined earlier, and we've only got that one revision 23 as that active document. If I go back to Cloda, might understand this or try to find out there's some outstanding work that needs to be done. What policies do I need to acknowledge? Directs me down to my workload. How do I report an incident and different elements there? If I have that capacity to edit documents, show me the documents that are due for renewal. Cloda is going to direct me straight through to the analyses here, where we've got 2 documents that are overdue for renewal. We've got the owners, and I can push out a notification saying you need to action this. I can export that any time, and if I push it back in my chart format, you'll be able to see what's overdue and so on with my acknowledgement. As I mentioned, we keep these documents up to date. So we've got 97% compliant here, just those 3 that are out of date. If I click on the link, we can compare the documents by the type, what department they apply to, who the owners are, the authors, and so on. If I'm looking at the compliance with my documents, so those issued to my staff, have they opened them? Have they acknowledged them? What's my level of compliance with that document within the system? In my demo environment, obviously we've got a lot of profiles in here that are non-active, so we've only got 14% compliant, but I can filter that down to one specific person. So if I look myself here, we can see that Louis is 91% compliant, still have that remaining outstanding copy there. If I look at where we're outstanding, again, fully interactive, so I can click between the acknowledged and outstanding. I can see by department, so I can compare my management department with my admin team, with my nursing team, to see what's outstanding or how we are compliant across my organization. And as some of you might have multiple homes, we can filter that by multiple locations. So within here, I've got Galway and Dublin, so we can categorize each of those different departments where my staff live in terms of location, the department, the document, and we can even update all of our different HIQA themes against them. So this allows you to distribute your documents. So when I do those updates and push them out to all of my staff, I can send them to everybody. So if it's that open disclosure policy, everybody will get that document that needs to be read, understood. And if you insist on the quiz being part of it, you can have all that information. Whereas if it's just applicable to one department, I can tailor it that gets distributed just to those individuals. I'm going to leave it at that for today because we're very much focusing on the policies, procedures, and the management of those, and how Cloda can provide rapid access to the information you need. But we do have additional features coming, as I said, mandatory training requirement, incident reporting, and in time we'll have our risk registers and risk management, and we also have a full audit module coming later this year. So on
Excellent. A
that, I'm
home
going to
for
stop.
everything.
A home for
A
everything.
home for everything. Well, thank you very much to everybody who took the time to visit with us today, and I hope it was informative. And certainly, if you have any queries or you'd like to discuss any of our services further, any of us would be free to talk, but certainly Louis, I know he loves to have a chat. And with that, we'll say adieu for now, and we'll see you again, hopefully, for one of our subsequent webinar sessions. Thank you very much, everybody.